All right, well, we're going to talk about pain. I think that's appropriate at this point, where it's sort of the sixth vital sign that Billy mentioned, and the reality is it is something that we need to sort of address. So as soon as we pull these up, we'll talk about it. I am from the crosstown rival sort of county hospital in Los Angeles. I'm from Little County, which is Harbor UCLA Medical Center. And I've been there longer than Billy's been at USC, but not by much. I've been there 27 years. And after 27 years in a county hospital, you get kind of an interesting view of the world we'll go into a little bit as we get to know each other better over the next 4 days. Let's start, though, together and talk about sort of analgesia and procedural sedation and a couple things about pain. We get, sort of depending where you are in your career, we get into this weird kind of, you're not getting any pain meds out of me stance in the emergency department that I want to talk a little bit about as we go through this. I don't know if it's just 27 years of exhaustion, I'm just done, I'm tired, but the reality is one of the things we can do is take pain away. And the reality is, for those of us that work in the emergency department, it is the most common reason people come to see us. Some sort of pain. The pain in their ankle when they broke it, the pain in their belly when they have a ruptured ectopic, the back pain they have because they have a ruptured disc, the migraine headache they have because they really do have migraines. The reality is people come see us for pain. And it is considered by the EMTALA law to be an emergency medical condition. Pain in and of itself, regardless of the cause. The reality is, for whatever kind of pain is out there, we have more medicine than they have pain. And we can fix it. And it's sort of one of the things that we can do that is compassionate, that shows that we actually care, and we're not number counting, and we're not bean counting, and we're not in an adversarial role. And each of us is different on this, and I'm sure each of you has your own horror stories and frustrations. But I think if you sort of de-escalate this push-pull thing about pain, it becomes a much more pleasant place to work in the emergency department. And we'll get into some of the techniques a little bit as we go through this. But the reality is pain is a big reason people come to see us in the emergency department. It just is. It's one of the most common reasons. And our goal, honestly, is to get on top of the pain and control it as early as possible. People are more pleasant. People give you clearer histories. People give you a better exam if they're not in pain. So part of this, I think you should push it to the very front of your encounter. The reality is we don't do this well. If you look at the studies are really embarrassing. For people of color, for children, for elderly people, people with I fracture my femur, and you give me acetaminophen? Are you flipping crazy? Seriously, honestly, we don't do it well, and the studies say across the board we don't. So one of the things that I think makes our lives easier is to start every encounter with, "Hi, Mr. Smith," or my place, "Hi, Mr. Gonzalez, how you doing? Looks like you have a pretty bad fracture there. I'm Dr. Birnbaumer. I'm going to take care of you. Would you like something for your pain?" As part of the intro. Then they don't have to do the moaning and the groaning and the 11 out of 10 pain score to get your attention. They actually can just say, "Yeah, I would. I'd like something for pain." And if they say, "No, I wouldn't," offer it again. You don't have to be in pain. Honestly, I can fix that. You really don't have to suffer here. I don't have to knock you out, but I can certainly make you more comfortable. It's amazing how often on that second time you offer, they'll say, "Okay." And if they still say, "No, I really don't want anything," that's fine. Document it in your chart. And it's not patient refuse. They're not refusing. They're declining an offer from you. So it just de-escalates everything. It takes that sort of adversarial thing out of the loop. And if you make it part of just the introduction when you go talk to somebody, it really is one. And I also recommend you make it as part of your drive-bys. As you're running around the emergency department, and you're sticking your head in a door saying, "How you doing? Did you get your x-ray? I'll go check on that. How's your pain?" It makes it much better. They know you're paying attention. They know you care. And honestly, the placebo effect of that is tremendous. Sometimes their pain does get better just because you care. So I think that's really important. And I think because there's no way to test for pain, I think it's a useful thing to do. Now, we do these pain scores. I hate pain scores, don't you? I really, honest to God, hate pain. I hate it. It's ridiculous. I think it's very helpful to say, "Are you in pain, yes or no? Do you think it's bad or not? I gave you something for your pain. Do you think it's better or not? A little better, a lot better?" That's much more communicative. That's much more interpretable than a scale that's out there of pain. The key is to do some sort of idea of where somebody is and how you're doing, whether you do a pain score or not. The reality is just addressing it is the key. There are ways to take care of pain, though, that are short of drugs. We tend to default to picking up a pen or typing in an order into our EMRs or writing a prescription. The reality is there are a lot of other ways to take care of pain. I had an amazing experience doing an LP in about a 10-year-old girl who needed an LP pretty significantly. She had a high risk for, and she turned out to have meningitis. And her abuela, her grandmother, sat on the opposite side of the gurney while I was behind this 10-year-old who was terrified of having an LP, terrified. And I listened to her abuela walk her through her favorite park. She talked her, remember the duck pond? What do the ducks look like? Oh, remember feeding the ducks? What was your favorite part of feeding the ducks? And that little girl never moved. One iota. I don't think she noticed the anesthetic needle. I don't think she noticed one bit. Her grandmother was doing visualization. All of the star athletes do it. It works. Visualization is helpful. You can put ice on something. That's helpful. You can do acupuncture if you're into that. That works beautifully. I mean, and actually some insurances now actually cover that, how progressive of them. You can do things like your dentist does. If you have a good dentist, when they take that needle that's about this long that they have to put in to give your anesthetic, a good dentist will grab your cheek and jiggle like crazy. What that's doing is at the gates of pain, as it sort of transitions its way all the way up to your brain, it blocks it. Vibration is beautiful. You could do that when you're injecting, let's say, around an abscess, or you're injecting to do a digital block. Jiggle the skin a little bit. Gives you another technique to decrease pain. It's remarkable. It's very helpful. Okay, elevation. Take something that's, it's throbbing when it's down here. Well, put it up there so it doesn't hurt so much anymore. So lots of things that are short of pharmacologic measures work beautifully, and you can integrate them into your standard practice. EDs that focus on being pain-free emergency departments do all of this stuff. They have this whole armamentarium of things that they can do, but short of actually giving any kind of medication at all. If you, and we can be short of even things like pills or, God forbid, opioids. You can do things like give local anesthetics. A really good practitioner will go see somebody who whacked off the tip of their finger in the, I don't know, the skill. My husband's at home working with a skill saw right now. He said, I'm focused on cutting off fingers right now. I'm not sure what the deal is. But if they come in with a digital tip, cut off their finger. You do a good exam. You elevate it so it doesn't throb so much, and you put in a digital block before you send them to X-ray. Why should they throb and bleed all over X-ray? You can make them feel much better with things like digital blocks. It's a wonderful practice in sort of that pain-free ED approach. If you have a shoulder dislocation, inject it with lidocaine or bupivacaine. Something lasts even longer. So you can actually take the discomfort away. Sometimes that's all you need, and you can relocate it with just that. You don't even need to sedate them. So there are a lot of things that we can do, first, short of medications of any kind, and then short of doing anything either orally or parenterally. And if you get really good at this and kind of pour it into what you pull out of your bag of tricks, you'll get very good at this. If you get to drugs, the World Health Organization has developed what's called the Analgesia Ladder. And the key to this is once you get to using drugs of some sort or another, there is a progression here. But a couple things about the ladder I think are interesting. You do not have to have your digit amputated. You do not have to have 80% second-degree body surface area burns to qualify to have opioids. Anything above mild pain. So mild pain is I have a little first-degree burn, I put some ice on it, I maybe need a little bit of aspirin or Tylenol, that's it, and I'm done. But I have a big laceration that's really hurting me, or my burn is now, my forearm, it's mild to moderate pain. Now it's worthy. It's worthy of doing something that adds even an opioid. So the basics are all in there, but you get to even just to moderate, kind of higher end of mild to moderate pain, and it deserves something real. And especially think about it, that's what they're there for us, is to help them feel better. So that's what this sort of analgesia ladder does, this kind of progresses up from that. When you pick a drug, you're going to pick it based on a lot of considerations. And I have to tell you, this is one of the things about being a medical practitioner that is awesome. You have this amazing array of medicines you can choose, and you can pick the perfect medicine for most people. You can pick the exact right thing to fix them for whatever they happen to be there for. Depending on the route, depending on how long you want it to last, how quickly you want it to kick in, whether there's contraindication, side effects, you get to be the expert and pick the perfect medicine for any individual patient. It's so much fun. And I have to tell you, acetaminophen is an amazing pain medicine. It works. The worst thing we did to acetaminophen is make it over the counter. Nothing works if you can buy it at the drugstore, right? They have to come, if they come to you and you say, have some Tylenol, it's like, are you flipping kidding me? I can go buy that in the drugstore. No way. You can say, you know, you need the extra strength stuff. It's all in the spin. But the reality is acetaminophen, now it is antipyretic and analgesic. It is not anti-inflammatory. So if someone has true, honest-to-God inflammatory pain, their rheumatoid arthritis is kicking up or something, that it isn't as good a drug. But the reality is it's a wonderful drug. It works just fine orally. It works just fine rectally. The dose may have to be a smidgen higher, but it works just fine rectally. And the new IV form is being marketed like crazy, but there's no evidence that it is any better. Okay, no evidence that it's any better than giving it orally. So you don't need, it is a great drug. Now, the other bad thing that happened to acetaminophen is that some people get liver damage from it. You shouldn't be taking more than 4 grams of acetaminophen a day. And actually, to be honest, that should be effective analgesia at 4 grams or less a day. That should be effective analgesia. At that 4-gram point is the break point where people who are malnourished or people who have liver disease may run into trouble with their liver. It has gotten way more press than is real. Think about the umpty gazillion doses of acetaminophen that are taken in North America every year. Cumulatively, I think it's uncountable. And the number of people who've truly died of liver disease because of it is really vanishingly small. This is a very safe drug. It is very effective. It may take a little spin on your part, but this is a great way to treat just mild pain. Remember, we're in the mild part of that sort of World Health Organization ladder. Non-steroidals kind of give you one little extra benefit on that. They are non-steroidal anti-inflammatory drugs. Couple things about them, though. What you get in the anti-inflammatory component of this and the things that are great for things like colic, biliary colic, renal colic, you do pay a potential price. The price you may pay is the price of somebody who basically has problems with gastritis from it. So ulcer patients probably shouldn't take it. Older people, one single pill can erode through their stomach. So that can be a problem. And it causes salt retention, so hypertension gets a little out of control, and CHF can get out of control. It can cause some renal dysfunction. They aren't perfect medicines, but in general, they're relatively safe as well. And what you do get over and above the acetaminophen is that anti-inflammatory component. That's what you get in addition. We forget that aspirin is a non-steroidal drug. And in fact, aspirin now somehow has been relegated to vascular disease. You have, TIAs or you have heart disease. That's what aspirin's for. Aspirin, people chewed on the bark of trees, which basically is where the salicylates come from, for years, for thousands of years. It works beautifully. It works wonderfully for pain. And I kind of recommend thinking about sticking it back in your armamentarium of agents to try. One of my colleagues had recently had an injury and started taking aspirin and just came in and just singing its praises. He said, my goodness, it's beautiful. It works great. It does. Now, it's a non-steroidal. All the issues that happen with non-steroidals happen with aspirin as well. The thing about it is if you really worry about somebody's guts, give them enteric-coated. It works just fine. So aspirin, kind of stick it back in your armamentarium, not in children. Right? Rise syndrome, which we virtually never see now, we never see because children don't get aspirin, nor should they. So kids under the age of 10 shouldn't be getting aspirin. Now, we often default to ibuprofen or naproxen. They are both superb drugs. They come in, 1,000-tablet jars at Costco. They're wonderful, and they do add anti-inflammatory components to their analgesia. But know that for all of these non-steroidal agents, the pain control is in the lower doses. So for ibuprofen, for example, 200 to 400 milligrams is pain control. You don't get the true anti-inflammatory hit until you bump the dose up to 600 to 800 milligrams a dose. The problem with that is now you do increase the risk of side effects significantly. So you have to kind of weigh this. And honestly, non-steroidals in elderly people are something you should really be concerned about. I would be a little hesitant with the non-steroidals because of the problem with their GI tract and their congestive heart failure stuff. But know that these are very good agents for adults and children. Now, Ketorolac, which is incredibly commonly prescribed, is the only parenteral non-steroidal agent we have in the United States. I will tell you, it has been banned in more than 8 European countries because it is actually highly toxic. It works well for things like let me give you a certain example. You see somebody with biliary colic or kidney stones. You know that non-steroidals, Ketorolac, work great for kidney stones or biliary colic. So you decide that's what you're going to use, and that's fine. Be careful with the dose. It depends on a lot on age and their renal function, et cetera. You have to be careful what dose, what route. That's fine. Just know that 1 in 4 people are not going to respond to that agent. So you have 1 in 4 people writhing around on a gurney with a kidney stone, and they're not going to respond to this. It's just one of the problems with this agent is because of its metabolism, because of its pharmacokinetics, 1 in 4 people will not get pain control from Ketorolac. So don't count on it as the only thing. And the reality is it hasn't really been proven to be any better than a really good slug of oral ibuprofen. So it's fine to give. People like the sort of placebo effect of a shot or an injection of some sort, but just know it's not magic. And 1 in 4 people with colicky pain will not respond to this agent. So it's not the panacea. It's not perfect. What are sort of the big guns are the opioids. Opioids are magical, honest to goodness. Laudanum, which is what they used forever, opium, and they can you chew on poppies, and it is magical, magical medicine. If you've ever had serious pain, it is remarkably a wonderful thing to give people. Now we have, and this is the burn patient. This is the person who has a ruptured appendix and serious abdominal. You know what? This is the stuff. This is what works. You have lots to choose from. You have parenteral agents to choose from, and you have oral agents to choose from. And the key for us in general is that for the parenteral agents, morphine, fentanyl, and Dilaudid work the best. For the oral agents, you can use oxycodone or hydromorphone, but I have to tell you, codeine, when it's been tested, codeine and propoxyphene, so those 2 agents, when they've been tested sort of head-to-head with even just acetaminophen, don't do well in true placebo-controlled studies, where the people have no idea what they're taking. They just know they're taking something. It doesn't work any better than acetaminophen alone. Now, some people individually seem to do better on it. That's fine. Just know if you really want to use a good pain medicine, that's not the one. Okay, propoxyphene and codeine really aren't the best. And again, people are individually different. That's fine. But just know if you're picking something out of a hat, it doesn't work terribly well. Now, the parenterals, if you have somebody with a lot of pain, morphine is magical. Morphine is fantastic. It is dirt cheap. It kicks in 3 to 5 minutes. It lasts 3 to 5 hours. And I want to tell you something. The effective dose in an adult is 0.1, or the effective dose in anybody, is 0.1 to 0.2 milligrams per kilogram. If you're writing 4 or 5 milligrams as your first dose for serious pain, you're underdosing. Please get in the habit of erring on the side, if it comes in your 4 milligram, sort of vials, err on the side of giving 8, or if it comes in the 5s, err on the side of giving 10. So you're sure you're giving adequate doses. Again, our goal is to get somebody comfortable, so give them a dose that actually makes a difference. Don't make them beg for more by under-treating them up front. Again, our goal is to get on top of the pain, control it, and then we can kind of just ease through slowly as their pain gets controlled, stays controlled. So morphine is wonderful. Dilaudid is much more powerful. We went from using Demerol, which we are now Demerol-free at our place. A lot of hospitals are. There's a lot of debate whether that's appropriate or not, but separate from that, when we got rid of Demerol, a lot of the residents where I work started using Dilaudid, but didn't make the calculation adjustment for the dose. It's about 5 times as powerful as is morphine. So when our patient got a 5 milligram dose of Dilaudid and stopped breathing, it became quite clear that we needed to make it obvious to all of the residents that they needed to back down on their dosing when it came to Dilaudid. Again, equipotent doses is your job. That's what you need to do. Now, fentanyl is magical. Fentanyl is amazing. Fentanyl does a couple things that the others don't do. Fentanyl, first of all, kicks in 60 seconds. If you need someone's pain controlled right now, it works in 60 seconds. It is mega strong. It's in microgram dosing. Microgram dosing, because it's so strong. It's 100 times stronger than morphine. The thing is amazing. And the thing that's really beneficial to us in the emergency setting with fentanyl is that it does not cause histamine release. If you have somebody who's hypotensive, a trauma patient who's bleeding, if you have somebody who's septic because they are gangrenous leg that's just killing them, this is a wonderful drug because it's going to have a minimal effect on blood pressure compared to the other narcotics that are out there, the other opioids that are out there. It's wonderful. Now, the downside is it doesn't last very long. 5 to 10 minutes and it's gone, like really not there anymore. So if you're going to use it for a rapid sort of get on top of that pain and then you want something longer, you may have to go to something like Dilaudid or morphine instead. Wonderful agents. They're best used, honestly, in sort of get on it with a good dose and then titrate and keep people at an effect. That's sort of the best way to use these agents. Now, if you're in the habit of, or we're taught to, as I think many of us in this room were taught to, of writing a narcotic plus something. Vistaril, Phenergan, those are the most common. I will tell you that if you were taught that the reason to do that is it increases that action of the opioid, that's wrong. There is now a huge body of literature that says adding that adjunct doesn't actually increase the efficacy or the potency of the opioid at all. And to be honest, since one of the reasons we give those is a lot of these narcotics, these opioids, cause nausea as one of the side effects. The reality is most people don't get the nausea with it. So you're using something that's more sedating, doesn't increase the opioid efficacy, and can cause some trouble when you may only need it in 5 to 10% of patients max. And you may be able to give agents that don't cause a lot of sedation, like ondansetron, where you can use something else. So if you are in the habit of writing two drugs together when you write an opioid, I'd like you to rethink the practice, because honestly, the literature doesn't support it. It doesn't mean you're wrong or horrible, but it just isn't really well supported in the literature. Now, oral opioids have gotten a lot of bad press. Okay, oral opioids, because they are so widely prescribed, they are so hugely abused, and people are now dying of these. These have gotten a lot of bad press lately, but I think inappropriately. Yes, we need to be careful how we prescribe these. Yes, people shouldn't be getting hooked on them and taking them every day, and God forbid children or kids or teenagers taking them for fun, which they do. They go pilfer through the medicine cabinet and take them for fun. All that being said, these are wonderful pain meds. If you go home with a bad tib-fib fracture and you're going to see the orthopedist in a couple of days for definitive care, you need a good pain medicine. If you have a bad burn, people need good pain medicines at home, and these work. They're best for that sort of moderate to severe pain people may have at home. They work beautifully for that. Now, if you prescribe them, just like if you prescribe anything that might be sedating at discharge, so these meds always do. Always instruct people about please both document it in your chart, say it to them verbally, and it'll be hopefully on the pill bottles as well. Don't drive. Don't operate machinery like the skill saw my husband is using right now. Don't operate machinery. Be careful with this, because don't drink while you take these, because it certainly can cause the problems that we're all aware of. The other thing about these particular agents is in elderly patients. I'll tell you, bad pain in an older person. My 94-year-old great aunt just fell. She's very active. She fell at the DMV getting her license renewed. Gotta love her. She drives every day to church. She opens the church every day. She goes out for coffee with a friend. She plays cards 3 times a week. She's amazing. She's amazing. She fell at the DMV and suffered a type 2 dens fracture. She basically cracked off the top of her dens and was in a significant amount of pain, fortunately neurologically intact. The problem is, how do you manage a 94-year-old's pain? Acetaminophen's probably not enough. Non-steroidals in a 94-year-old are fraught with difficulty, but they don't sedate her. The opioids are sedating, and she's now walking with a walker with her big old thing on. But what do you do for pain in someone like that? This is a problem. Opioids are okay, tiny doses. Okay, half of what you might give a normal adult-sized person. Start with that and see if it works, because these definitely can cause sedation and falls without question. Now, the specific opioids available to you, we sort of have the hydrocodone group and the oxycodone group. Oxycodone is sort of considered the big one to give Percocet, Percodan. The hydrocodone is the Lortab or the Vicodin. All of them work. Okay, all of them work. Some of them are available in elixirs, so there's some you can give to kids. This is all very helpful for people that are having significant pain at home. So if you're discharging somebody from the emergency department and their pain is mild, so that little bit of a first-degree burn, everything's okay, that person can go home with something like acetaminophen or even aspirin, again, not in kids for the aspirin, and then maybe low doses of nonsteroidals and good local care. But anything more than that, you're going to inflammatory pain, give that nonsteroidal on purpose in the anti-inflammatory doses. And anything moderate to severe pain, go ahead and feel free. Give them an opioid if they need it. I often will give both. I'll give something like a nonsteroidal and say, give this one a go. If that's not enough, here's your opioid as your backup, so that they know they have something that will control their pain. So that's sort of the approach to pain. De-escalate the sort of battle part of it, get on top of it up front, make it part of your drive-bys and your introduction, know how to use the agents well, and send them home on the right stuff. This is something we can offer anybody who comes to us that's having discomfort. Now, sedation is a different ballgame. Sedation, the thing about we do procedural sedation all the time in the emergency setting, as we should. And I'll tell you, I remember the day where we didn't. And all we did was brutane everything. We tied children down in a papoose. Think about what we did. We strapped them down, we held them down, we let them scream bloody murder, and did whatever we needed to do. Oh my God, this is awful what we used to do. Now we can procedurally sedate people. However, This is a big deal. Okay, this is a big enough deal that the CMMS, the Centers for Medicaid and Medicare Services, have delineated how we need to do this. They have defined, the Joint Commission, they have defined the different levels of sedation. They have basically obligated us to put a physician at bedside during procedural sedation. If you don't do that, I have to let you know, you're probably risking, if there's a bad outcome, risking some trouble. Now, if you have some setup where you have a protocol because you don't have physicians around all the time, and you have the ability to do procedural sedation, I think you're walking a really fine line. They wanted 2 physicians at the bedside initially. They've now backed off and said it can be a physician and a credentialed nurse when you're giving procedural sedation. But just know this, the reason for this is if you inadvertently overshoot and somebody stops breathing and there's a bad outcome, you did something that was voluntary. You didn't have to do it in the first place. And if you did it wrong, now you have the entire medical legal burden on your back. So this stuff is really important. It can be done absolutely well. We are somewhat rigidly put in a box as far as how we should be doing this by all the agencies that accredit us. So know that that's out there. And as a result, protocols are highly advisable. At our institution, we have a whole thing. The nurses just all big, heavy sigh when someone says the words procedural sedation, because the whole thing starts to sort of go down the pathway. We have a form, we have all these things that have to be done, and checks and its balances, et cetera. It's safer for the patient. It's better to do. So just know all of this stuff needs to happen. It's really, really important. Once you decide to embark on that, a couple things by the way. So giving fentanyl, for instance, as some pain control, or giving a little bit of, let's say, Midazolam as a little bit of an anxiolytic, if those are your only goals of those medicines, is not procedural sedation. Procedural sedation is defined by intent. The intent I have when I give these medicines is to snow the patient so I can do X procedure. If that is your intent, that is procedural sedation. If the intent is, I just want the patient's pain controlled, I'm going to sew them up or whatever, that's not procedural sedation. So just know that it's intent-based. That's how it's defined. And once you've decided and you have all the protocols set up, and you have all the equipment and everything else that needs to be there, now you have to pick the drug. We have lots to choose from. Some of them are major big guns. Some of them aren't so great, actually, for sedation. We'll talk about some specifics in a second. But what you're going to, like any other medicine, you're going to choose them based on what are you looking for, how long do you want them, do you want them to not remember things, do you want them to have pain control, do you want, it all depends on what you want, how quickly does it kick in, et cetera. You have lots to choose from. We're going to touch on some of the big ones briefly, and then we're going to kind of wrap. Midazolam is a benzodiazepine. What benzodiazepines do for you, they're not analgesic. It is not a pain medicine, which is why it is often combined with something like fentanyl when you're using it for procedural sedation. What this does for you is gives you amnesia. You don't want to remember some of the procedures that are done. We cardioverted an elderly woman not that long ago who we had to shock her with 200 joules of synchronized cardioversion, and we had trouble sedating her because her blood pressure was so low. We shocked this wonderful elderly African-American woman, who was a Spitfire actually. We shocked her and she said, well, shit, that'll wake you up in the morning. It's like, I'm so sorry. We really couldn't give her too much because her blood pressure was so low to start out with. So I would have loved to have some of this on board so she at least wouldn't remember having said, oh shit, that'll wake you up in the morning. So this is wonderful in that regard, but I have to tell you, as a sole agent, it's not a really great procedural sedation drug. And if you combine it with fentanyl, which is often done, you really magnify the risk of hypoventilation, okay, of their underbreathing. So just know that that combination has a significant risk of people having hypoventilation. So you can use this, it works just fine. A lot of people have defaulted to ketamine. Now ketamine is amazing. It was a horse anesthetic. Basically, it was used for horses forever. They want it back, apparently, now that we're using it as some sort of recreational drug. But ketamine does a couple things that are great. It causes dissociative anesthesia. It is a chemical pith. The lights are on, nobody's home, but I am breathing, I am swallowing, I'm protecting my airway. It's beautiful. It's a chemical pith. It's amazing. It's wonderful. It's an analgesic. It's a pain medicine. It's amnestic. You don't remember anything. It is an amazing drug. It is absolutely fantastic. The dose needs to be right. It's there on your sort of doodad, but 1 to 2 milligrams, either IM or IV, work beautifully. You do not need to combine it with other medicines routinely, like atropine or a benzodiazepine. You don't need to do that routinely. The downside, though, of ketamine is that if you've ever had this happen, my first time I used ketamine, which was 20 plus years ago, I gave it to the wrong first person to give it to, who was a Vietnam vet. And I gave him ketamine, and the procedure went beautifully, and on emergence, he was back in Vietnam. And he turned the gurney on the side, and he was crouched behind it, screaming about Charlie and throwing things, and really thinking he was being assaulted. It was unbelievable. So emergence is the thing that is one of the major things we worry about with this. And I'll tell you, most people, if you do it right, you can take them to a lovely place. We did this recently, and a guy we had to do basically he had a horrible fracture. We reduced it, and we talked him through. So what's your favorite thing to do? I love to go surfing. Oh, excellent. Let's talk about surfing. Well, I like the waves and Huntington Beach, and I love it. And then he went off to the sort of ketamine state. And then he came back, and he was still surfing. Oh, and like the waves are really great. And he had no emergence at all. His emergence was a great ride on a wave. I mean, it was great. Set it up. Okay, you can prime people for this. So emergence does not need to happen. And the hypersalivation laryngospasm is really, really rare. So ketamine, great. Okay, wonderful agent. Etomidate, which was originally used as an induction agent for intubation. The thing about etomidate is that you can use it half dose for sedation. Couple things about it. It burns on the way in. So when the people are getting put out to get, to be intubated, they don't usually notice. But for procedural sedation, they do. It burns on the way in, and some people get myoclonus. We were relocating an elbow, and this woman got horrendous myoclonus. Her family was at the bedside. It looks like they're seizing. Okay, that can be a problem, and it makes something like a relocation really difficult. So etomidate kicks in quickly, doesn't last terribly long, but not super great for sedation. Ketamine's probably a little better. And then a lot of us are now using the milk of amnesia. We're using Propofol. Now, Propofol is magical, but I'll tell you one thing about Propofol. You have just leaped over any sort of mild to moderate sedation, and you go right to deep sedation with Propofol. They're out. Out, out, out. Completely out. You can't use it in people with egg or soy allergy, and that should be part of your protocol. Ask that question every single time, because it's basically, that's the formulation. That's why it looks so milky. You cannot give it to them. And the dose of this basically is done in a bolus and then titration. Okay, it works wonderfully. Be careful with the elderly. They get hypotensive. Be careful with somebody who's hypovolemic. They get hypotensive. And a lot of people will stop breathing, up to 10%. You can usually either get them through it because you have oxygen on, or you can actually bag them a little bit. Virtually no one needs to be intubated after Propofol. The problem with Propofol was that hypotension thing. One of the problems with ketamine is the vomiting thing. What if I combine the two? If I don't want them to get hypotensive from Propofol, ketamine is actually a catechol releaser. Ooh, cool. If I don't want them to vomit from the ketamine, Propofol actually can suppress that. Ketorolac is basically a 50-50 mixture of a 0.5 milligram per kilogram of both agents mixed in a single syringe. The studies on this are very promising. It isn't super better than either one, but it is actually very well tolerated. People really like it. The patients like it, the practitioners like it, the people stay breathing. It's actually quite lovely. So that combination is really worth considering. So overall for sedation, do it with the right protocol. Having a physician around is really the way to go on these because they're such a high-risk thing. Pick your right agent, and there's lots of different things to choose from, and know what you get and what you don't from the agents. One last thing about Propofol. It is also a sexual disinhibitory drug. So, if as the patient is coming out of sedation, they make a pass at you, it has nothing to do with how attractive you are. It has everything to do with the drug itself. Apparently, after one of my knee surgeries, as I was coming out of the Propofol sedation, I either offered to do or something, the anesthesiologist, who to this day will walk by and go, no idea what I offered. All right, thank you.